All right, we have Dr. Vali Mohammed and we have Jeff and Ivan from Nalu Medical, and they're going to be showcasing some different ways to go after peripheral neuralgia. So welcome, guys. Good to see you.
Thanks for having us.
Good to see you. How are you?
Good to see you.
Good to see you.
Here's your slide presenter. Great. And you can just fast forward and push forward. There you go.
All right, guys.
All right.
All right, so, okay, guys. Well, thanks for having me on. Ali Vali Mohammed. So I practice in New Jersey here, private practice. Thanks for having me on.
Somebody locals. Is this like a local deal for you, AJ?
You know, the Northeast is blessed with great doctors. What can I say? What can I say?
It really is.
We're glad to have you guys here. It's awesome.
Appreciate that.
Yeah.
So today, guys, I'm going to talk to you about the Nalu neuromodulation device. What really excites me about this device is its micro IPG and its ability to provide, in this small form factor, really robust therapy. And not only for spinal cord stimulation, but also for peripheral nerve stimulation. And with that, also be able to provide a novel waveform for our patients. So I'm going to spend the majority of today talking about peripheral nerve stimulation, but I do want to take a brief second here to talk about spinal cord stimulation. And the question really becomes, and we're all interventionalists, we all use spinal cord stimulation. Where does this fit into our practice? Why Nalu, right? How do I integrate this into my practice, this new device? And so, you know, I like statistics, and recently I read a statistic that said maybe 25% of patients who were offered spinal cord stimulation end up declining the therapy.
Well, that's true. I agree.
Yeah.
That's absolutely true.
I don't know about you, but a large reason in my practice why this seems to happen is because they become a little bit gun shy when it comes to the IPG and the size and having metal in their body, right? This can be a big turnoff for the patient. And so why is that, right? So the size of a header is typically, you know, what's going to limit the size of that surgical incision that you make, and maybe that's 4 or 5 centimeters. But with this system, right, you can end up with a much smaller incision, a much smaller IPG. So the typical size of an incision would maybe be about 4 or 5 centimeters, but in the case of this incision, it would only be about 1 centimeter, right? And the difference in volume there would be 40 cc's from a typical conventional spinal cord stimulator. But again, this system would only be about 1.5 cc's. So I'm all about analogies, right? We all have to have different talk tracks with our patients. So when I talk to them about the size of a dime, or I'm a big food analogy guy. So I tell them, you know, we're going to put a pasta noodle in the epidural space, and then we're going to go ahead and, you know, we're going to put a Tums in the back, right?
We're having a lot of cooking analogies.
I mean, I'm
We're
hungry.
talking about spice
What
in the
is
morning.
Tums?
Now we're talking about Tums. It's going to be a cooking show soon.
That's
I
right,
like
it could be, you know.
Hey, you never know.
Go
in
back
the
and forth.
direction.
MedEd chefs. I like it.
MedEd chefs. So, you know, with that, it leads me to the second thing, right? So oftentimes, you know, based on the size of that surgical incision, based on the size of the device that goes in, patients complain of a lot of pocket pain, right? This can be 20% of our patients, and I think it's something that we, you know, tend to push to the side, or is under-recognized, or really kind of, you know, we don't pay as much attention as we could. But those patients in your practice who are complaining with that, now you maybe have a different option for them, right? Or you have the patient who doesn't have much of a BMI, much of a habitus. This is an option for them. Looking at other things, I think that where this can really fit in, right, and identifying some of the pitfalls in the current market is longevity of the device, right? So our primary cells, I think the Cleveland Clinic study, I think in 2020 showed that the average primary cell lasts 3 to 4 years. An average, you know, rechargeable lasts maybe 7 to 8 years. And the large limiting factor for that is the battery itself, right? So with this system, it's a micro IPG, but the battery is actually externalized or removed here. So if you look over here, I have the actual battery, and that's the external part, and then the actual IPG is much smaller here. You can see right here, and take a look at that and see the actual size of this device. And we'll come back to this in a moment. But you can see, you know, that can make a big difference. And so again, talking about time here, so if you take the battery component out of it, you know, we estimate that this device will probably last about 18 years, and it's probably on the underside, right? Because I'll give you this analogy, right? You guys have a cell phone, iPhone, right? Eventually, at some point, you're recharging that, and the battery dies, right? And you either brick it and go get a new one, or you could take it into the shop, and you know, they'll give you a new battery. It's like new, right? The software still works fine. Right. The battery just died. And so that's kind of the analogy and how I think about this device and how it would integrate into my practice.
And that's probably a great way to relate it to the patient.
100%.
They all have phones, and they all think, oh, every 2 years I'm going to have to get a new phone, right?
Exactly, right. And that maybe leads us to another discussion, right? You have a patient who's maybe more on the geriatric side. Do you really want to be operating on them again another 5, 10 years, or are you kind of looking for another device? Or you have a very young patient, and they're like, man, I'm like 30? Like, do I really want to be having these surgeries over and over for the rest of my life, or can I do something that's maybe have a little bit less of a digital footprint, less operations, right? And that leads to other things, right? A host of other considerations we may take, right? Surgical risks, infections, and because of the small size and form factor of this, I think it arguably in those patients who I think are a little bit higher risk makes it a little bit more palatable to them, and rightfully so.
Absolutely.
You know, kind of looking again to the battery itself and charging issues. Sometimes, you know, the device charging problems could be maybe up to 11%. And in talking to my patients, how is this one a little bit different? Here, you know, they're just the IPGs in place. That's really going to be the brains of it. But the battery portion, you're not charging per se and sitting there all day to charge it. This is charging on their kitchen table. They get 2 battery devices, and they're just simply going to swap it out in the morning. When they go grab their cup of coffee, they can grab their new battery and simply slip it on the device. And we'll go into more of the specifics of that.
That's been a question for a lot of patients that I've seen.
Yeah.
Oh, how long am I going to have to charge? How often am I going
Yeah.
to have to charge? Is this going to be a nuisance?
Yeah, and this, again, it takes away that charge burden as well.
Correct.
Because you're not charging it on themselves. They can simply plug it into the wall and grab that new battery.
There you go.
Are you finding that Medicare and commercial insurances will allow patients to have 2 batteries?
Yeah, so it's an interesting question. So this device, you know, it does allow you to connect to two separate leads to the single device. Now, depending, you're bringing up a good question, right? What if you have separate limbs, right? You're going to need separate IPGs. So far, I haven't run into any issues, and I think if you do your correct medical documentation, it should be okay. I think that's going to be something that kind of the space kind of defines, right? We're really in a renaissance of this field. And now we finally have these options. And I think you bring us nicely to our next slide and talking about some of the different capabilities, especially when we're talking about peripheral nerve stimulation. I think with dorsal column spinal cord stimulation, this is less of an issue. But when it comes to peripheral nerve stimulation issues, some of the systems that are currently there do have some limited capabilities, right? And so this just, maybe your leads are only a certain length, maybe they're, unable to reach a certain area, maybe there's not enough contacts to cover the right area, or they're not tightly packed enough. Some of the systems don't have as robust programming capabilities, and we'll go into this, but this system really brings opens up like spinal cord stimulation options to peripheral nerve stimulation, which I think is really important. Now, if you look at this, and I talk to my patients about this all the time, you go 5 years ago, 10 years ago, right? We don't really have the ability to do a trial, and this system gives you that ability to do an apples-to-apples trial for peripheral nerve stimulation. So the same system that I'm going to trial you on is the same one I'm going to implant. And so for me, that has a lot of importance in terms of giving that patient that comfort with going on to the therapy, and also lets me know that my permanent is going to be successful for them, and reducing the amount of reoperations and things of that nature. There are options, in terms of longevity, right? There's some options on the market, maybe that are 60 days, 30 days, and some of them, patients get really long-stay relief, and that's fantastic. But what happens to those where the pain comes back, right? What do we do for these patients? We know, Medicare, you brought that up, is only going to pay for a certain amount of leads per year, right? We need to come up with an option maybe where they could have long-term therapy relief. And so this is, again, a way to integrate this into your practice.
So while he's transitioning, if you are a doctor out there that does spinal cord stimulation, and that's one of your main go-tos, everybody on their street corner, everybody in your neighborhood, everybody does spinal cord stimulation. The way you're going to differentiate yourself and make a niche and get referrals is to listen to this doctor today talk about the peripheral applications, because these will be a huge, maybe 50% of your practice of the stimulus you put in will be peripheral if you start seeking out extremity patients. But that's what you got to do in order to get even busier and more of a niche.
No, it's true. We had a doctor in our practice start doing it.
Yeah.
And he suddenly found other patients from other practices that came and sought him out because they had done a regular spinal cord stimulation trial and it failed, but they still had peripheral neuralgia. Absolutely true.
Right, and you're going to find those patients, right, who don't want spinal cord stimulation, and I can understand some of the hesitancy too, right? You just had spinal surgery, now you still have pain, and in their opinion it didn't work, right? Maybe they got rid of their neurological deficit, they still have the same pain they came into it with.
Right.
And so they're going to, or they had knee surgery, and now you want to do spine surgery, so the knee surgery, and why do you want to do spine surgery, So I understand the mentality where it kind of comes from. So let's get in a little bit to the actual nuts and bolts of the system, right? So if you shift our attention over here, we'll look a little bit at the actual device. And so you can see there's multiple different IPG configurations. Here again, if you can see my pinky nail, it's about the same size. And these are the different IPGs. So you can see there's an IPG that's connected to two 8x1s, or a single 8x1, or two 4x1s, or one 4x1. So again, different configurations depending on what you're trying to do. The leads themselves, as you can see here, there is an 8x1 contact lead. This is typically a more rigid lead, so you can steer it. So for example, in the epidural space. And then additionally, You can also see here, there is a 4x1 contact lead, and this 4x1 contact lead has a tighter contact together. So these are about 4 millimeter spacing, and here we have 3 millimeter spacing, so for tighter stimulation. And there's actually tines here. And this lead is great for the periphery because it's much more flexible, right? So you want the right type of lead for the right location. And so while this will be more sturdy and durable and steerable in the epidural space, this lead is much more flexible to kind of adapt with the flexion and contraction of the muscles in the periphery to prevent lead migration and fracture. So we talked about the actual IPG itself, and so here's the IPG, but there's the external therapy disc, and so this is simply going to align over the device, and that is going to connect. And when the patient's going to be able to feel the device, they know it's there, and then when it's positioned over, you'll actually get this auditory feedback, a beep, beep, beep. So this is a little bit different than some of the systems that maybe just have a receiver or an antenna, because this allows them to actually feel where that is, and then they, so you know, hear no evil, see no evil, feel no evil. Here we get all the goods here, all right? And then there's an adhesive therapy disc here, which will go ahead and it will hold the actual external component here of the battery, and the patient simply in the morning pops out the old one and puts in the new one. We'll get into some of the actual devices here. There is a precision tunneling tool, which I think is really unique and helps me be very efficient in my surgeries, and we'll get to that too. So that's another kind of exciting thing about this product itself. So that's the actual like nuts and bolts of the system. In terms of what are the type of capabilities that we have available here, the system is able to do tonic stimulation, it's able to do subparesthesia stimulation. As long as it's not proprietary, we're able to kind of attain that type of stimulation. This is a current-based system, so independent current controlled. What that means is we can really shift the stimulation to where we need it to be, okay? And so you guys know about this, but so in the spinal cord for tonic stimulation, I think that's really important to get really fine tuning of where you want the stimulation to be. But I think in the peripheral nerve stimulation, this is something we haven't seen the ability to do before. And now I think this gives us a lot more redundancy based on, you know, no matter where our lead's kind of placed, we can really shift the current to where we want it to be, giving us more programming capabilities depending on where that lead is. So for me, that gives me more options. On top of that, there is a proprietary waveform, the pulse stimulation pattern, and Nalu is kind of putting out some data. I think the current data right now for spinal cord stimulation at about 17 months out is about 73% relief in back and leg pain for spinal cord stimulator patients, and they are working on getting more information for a study for peripheral nerve stimulation. So, you know, again, this is something we have to do as stewards of the space. You know, develop more data so that we can continue to do these, you know, groundbreaking therapies for our patients.
For sure.
It is MRI compatible. So that's always questions.
MRI 1.5 or 3.0 Tesla?
1.5 Tesla, full body for SCS,
Okay.
working on it for PNS. You know, I think some of the variabilities has presented itself for no matter what system you're using because of the difference in location, but they are working on that and getting labeling for that.
That's great. That's a good point.
Big
'Cause
deal.
Patients always ask,
Yep.
what if I need an MRI later in
What if I
life?
need an MRI?
Am I going to be, you know, capped or blocked from doing that? So, yeah, great advantage.
All right, so this slide just really highlights the various locations we can have this device. In my head, if there's a named nerve and you can identify it as the distribution of the patient's pain and you can block it, then you can also probably do some peripheral nerve stimulation on it. And in my practice, I've kind of incorporated this earlier on, right? Radiofrequency ablation is a great tool,
Yes.
but in my head, if I can stimulate, I'll do that before I ablate. I'd much rather kind of maintain, some of these nerves are mixed motor nerves, right? And there are other consequences that we may have kind of downplayed in the past when we had less options, but now that we have the option to do some stimulation, we can really kind of hone in on that.
Now, this is a question probably for the audience. They might ask, do you always do a diagnostic block?
That's a great question. I do not always do a diagnostic block, but oftentimes I will, and that's more just to get to know my patient. There are some studies out there that basically show that a diagnostic block is not predictive of the peripheral nerve stimulation giving you good relief. I'm sure if we provide enough epidural anesthesia, everyone will get relief, right? But that doesn't mean everyone would do great with spinal cord stimulation. Really, I use it to make sure that they're going to get some type of anesthetic coverage in the area of their pain, and to really just get to know my patient. get to know their anatomy particularly, but I don't use it as an end-all be-all for whether the stimulation is going to work. So again, this is a system that allows you that trial to implant, and if you look at some of the LCDs as well, which I encourage you guys to do depending on where you live, that's something that's very important, right? You have to look at what you're supposed to be doing to do these types of therapies, and so now you can truly give your patient an experience of what it's going to be like. Here you can see the therapy disc can be placed in just about any location. Some patients use a therapy disc. Other patients, they do make also an adhesive band, say for in the upper extremity, or they don't want to use an adhesive. So it can go just about anywhere.
They can be doing something active with the adhesive band wrapped around the implant with the
exactly. And if they want to take it off for a short time period, right? We all talk about washout periods, right? They can take it off probably for an hour or so, and I think they're probably going to be still getting some sort of washout phenomenon or therapy as well, and put it back on. We don't really know, right? What's the right amount of nerve stimulation for PNS or SES even, right? Talking about dosing of therapy, and that's something we're still kind of working on. So, what are some good targets here? I think, again, like I said, if you have a named nerve, we can target it. I think this system is aptly designed to target some specific areas. And today, oftentimes when I talk to people, they'll talk about peripheral nerve stimulation, a little bit gun shy. Again, I don't do so much ultrasound. I don't know that I really want to incorporate it in my practice. But what you can do? There's a lot of targets that we all kind of usually use in our practice, and we ablate or we block, right? Geniculars, suprascapular, cluneal nerves, something we often forget about, right? And so we can translate that skill from fluoro to our peripheral nerve stimulation, and as things go on, we can then go ahead and combine that into ultrasound. So for me, for the geniculars, I think this is a really good option because if you guys remember that paper out in regional anesthesia in 2018, there's a variable course, and oftentimes we try to block it, and I don't know what you guys, my success rate is maybe 50-50, right? Or what do you do when initially they're getting great response for a year, then it falls off, right? You have to have an option for them. And so for me, this allows, I kind of go from anterior to posterior, and I try to cover the full diaphysis, metaphysis right at that junction, and usually I can get stimulation all throughout there. And these leads, I think, are long enough and they're robust enough where they're actually going to stay in place there, in a place where there can oftentimes be a lot of movement when you have contraction of the quadriceps. And again, you have the ability to connect both of these leads to a single IPG and get it kind of up and out of the way, which is nice, right? Not having it right at the knee. It's kind of a funny place, right? Otherwise, with these long enough leads, you can bring up in the thigh. No one's going to know, right? They could be in shorts or skirt.
It's out of the way.
It's out of the way. It's not externalized. So all really important things there.
So it's a system that's very flexible, gives you a lot of target options. Why don't you show us what you have here? Let's take a look at what this model has.
Yeah, let's come on in here. So right now we have a lumbar spine here with part of the pelvis here. And so, we're talking about cluneal nerves, right? So cluneal nerves, something I think that's kind of underdiagnosed. Maybe about 14% of patients with low back pain have cluneal neuropathy. For me, it's often, I think about it after I've done medial branch blocks and SI joint blocks. Why aren't they getting better? Their pains are right there. Oh yeah, the cluneals are there, right?
It's always forgotten until you get to a point where you're like, why aren't they better? What am I missing? And you're like, oh yeah, that's
exactly.
it. Yep.
So, these nerves, right, they come from the thoracolumbar, dorsal rami, they come up through the paraspinals and they pierce through that fascia there, that thoracolumbar fascia, right at the tip of the iliac crest.
Yep.
And so, typically I'll do a diagnostic block as long as the patient gets some temporary relief or some anesthetic in that area. I'll go, but again, the real true test for me is doing a trial. And so here I kind of already have one. We'll take a quick fluoro shot and I'll show you how to do it. And let's just kind of slide the C-arm in towards me a little bit here.
Again, let's deep dive just a little deeper into what cluneal nerve presentation looks. Not just I've thought of it. This is the last thing after everything else has been ruled out, but what does cluneal nerve pain look like? Where would they feel that, do you think?
Yeah, so for me it's that upper buttock, lower back, kind of, they're sort of pointing towards their SI, sort of towards, their PSIS. Maybe it's a little bit more lateral. It's kind of hard for them to describe, and I think it's because of that variable kind of trajectory and where the nerves are coming from and where they're going, depending on where they're getting the entrapment.
That vague, non-dermatomal area. Yep.
Axial low back buttock pain.
Correct.
Right? And oftentimes we mistake it for SI joint pathology or medial branch or spondylosis-related pain.
Right.
Maybe the failed back pain. And I think talking about failed back, right? If you had an osteotomy from someone who underwent lumbar surgery and they took some bone from there, or maybe they had a biopsy site from the iliac crest. These are common pathologies. I think another population population where it maybe goes underdiagnosed to be like a Parkinson's type symptoms, where those lumbar muscles are just so tight, or someone who has a lot of muscle contraction, oftentimes they're probably getting entrapment of these nerves.
So quickly, let's go through this. Let's show us the
Yeah.
procedure. We'd love to see it.
Absolutely. So if you go ahead and take a look here, I've drawn out, so normally the patient will do a wear trial. So not only do they get the opportunity to do a trial of the actual stimulation, but they get the ability to really test out what it's going to be like to have this external battery. And so the patient actually wears it for a week, and they're able to really feel what it's like to have this external battery component. And so prior to the actual implant, we'll take the therapy disc, we'll place it where the patient wants it, and we'll mark it off with a marker, which you can see right here. And then once we've placed that, we'll take the external battery, the IPG, and you can see the IPG portions here, and here's the header, and we make a mark where the header will go in. And that's where we'll make one of our incisions, and we'll get that in a second. So let's go ahead and take a look where we have this lead placed. So you can see right now we have a lead already in place here at the superior cranial nerves here at the top of the iliac crest, and we have an 8x1 contact lead kind of going across these nerves. And we started from medial and went to lateral. So let's talk about how we're going to do that. So normally, if we can open up the slide here, I'll go ahead and I'll palpate the slide, not the oblique. It's okay. We'll go ahead and I'll palpate for the PSIS, and that's somewhere about where I'm going to start, more medial.
All right.
And I'll identify that area here. And then my target is going to be more lateral here at the tip of the iliac crest. So you can go ahead and you can go and even slide a little bit further in. And you're going to start a slightly more medial trajectory. So if you take a picture here, and we're going to aim this needle towards the superior portion. Take a picture there. There we go.
So there is variability in the cranial nerve, just like there is of
There
everything,
is.
right?
There's a lot of variability. And
How
if you-
much can we count on getting on either side of our contact stop?
Yeah, no, that's a good question. So it depends on the size of the lead you use, right? If you need more of a larger area, I think you'd use an 8x1 contact lead. And because this is, again, in this osteofibrous tunnel, there's a lot of ligament there, I think that's really going to hold that lead in place.
So this is a great trajectory that you've shown. And on the other side of the floor, you can see that the lead has already been placed in its target zone.
Correct.
We've got a couple minutes left. I know you wanted to show kind of a pocket tunnel.
Yeah. So this
if
lead
you could
would-
do that for us, that would be great.
Absolutely. So this would go in through the TUI, and then the lead would go in.
Okay.
And once the
Excellent.
lead's in place, you simply move the stylet backwards, and you're going to see
That looks
this kind of get
fantastic.
placed down.
Oh, it's like you told the cadaver to work with you. It's amazing.
I think he's done this before. This isn't his first rodeo.
No, he's
let's
on YouTube once,
slide
right?
the C-arm out, and we'll do the pocketing. And so this is one of the great things about this, the device in terms of pocketing. So here, this would have been where our area was for our IPG. Again, it's about a 1 centimeter incision. Make a small incision here. And at this point, there is a precision tunneling tool, so there's no more, tons of undermining and a larger surgical incision.
Right.
Instead, this is simply going to go in between the layers here down in the, underneath the fascia and the deep dermal. You're going to go ahead and just make a single pass. And this pass, let's move this other model out of the way.
There you go.
We'll go ahead and create a pocket here. And then there's a tool that goes and slides right on the back of the IPG. You can see there's a little nub inside and a little tool that is specific that slides in and holds it. You connect the leads which are coming out through this incision, and you simply go ahead and slide the whole device inside.
That is smooth.
Yeah.
Smooth
That's
criminal.
smooth. You know how many times we work with a pocket trying to make a pocket? That was so smooth.
Yeah.
Well done. You guys did an excellent job. You showcased some really great technology today, some great anatomy, and some problem cases that we see in our patients all the time.
Absolutely.
And you guys did a great job. Thank you so much.
Yeah, excellent job.
Thanks, guys.
Ollie, well done.
Yeah.
Got a question?
We got a question?
Absolutely.
Yeah, this is Imran from New York.
Imran.
We knew you'd ask a question sometime today, brother.
One of our med ed fellows.
This is really exciting and it's really cool and it's nice to have part of it externalized for the patient's experience, but also the operative approach. Can you just comment briefly on what it's like getting reimbursed and covered in a private practice setting?
Yeah, great question. I think in a private practice setting, right, the trial, whether you're doing PNS or SES, is something that you can do and it's feasible. It's also good for business as well. It's I've been having good success with it. In terms of commercial reimbursement for peripheral nerve stimulation, this is something, depending on your insurer, you have to check in your area. But Nalu does have a great team behind them that helps you to get these prior authorized. And so I think that, again, I've been doing well in my area.
Yeah, so it's worth mentioning Nalu Medical does have prior authorization services, so expert partners that can help you in both PNS and SCS, and also can be working with your denials too. So it doesn't have to be a de novo Nalu patient from the beginning.
That's great.
If you're in the middle of something and you're just really needing an expert that can kind of partner with you and work through the process, we have the teams and services to do that.
Awesome. Thank you guys. This was Nalu
Great
Medical.
question, Imran.
Great question. You guys did a
Appreciate it.
great job.
Yeah.